A very good evening to all of you. It is with great pleasure that I welcome everyone to the second session of the Virtual Stat Day 2021. This year, Stat Day will be held as a series of 3-day sessions under the theme Surviving a Pandemic, a Statistical Insight, with the objective of highlighting the importance of statistics during one of the most critical natural and social disasters of the 21st century. The topic for today's session is quite an interesting one: how to model a pandemic using system dynamic models for decision making. So before proceeding, there is a small reminder. A Q&A session will be held after the speech. So if you have any questions, type your questions in the Zoom chat and send them to one of the hosts. We will direct them to the speaker during the Q&A session. So joining us today, all the way from Canada, is a very special guest. He is a product of the Department of Statistics of our own university. Moreover, he is one of the founding committee members and the third chairman of the Stat Circle for the term 2004-2005. He is currently the Director of Data Science and Analytics at the Ministry of Health, Nova Scotia, Canada. He's directly involved in COVID-19 pandemic response and modeling work done in Canada, and also a member of several national and international COVID-19 pandemic response task groups. Also, he has extensive training in health analytics and health economics and has widespread experience working in academia as well as public and private sectors in North America and Europe. He holds a master's in applied statistics, a master's in biostatistics, and a PhD in econometrics. So on behalf of the Stat Circle, let me warmly welcome Dr. 𝘔𝘰𝘥𝘵𝗵𝘃 to deliver the guest speech of Stat Day 2021.
Good evening, everyone. Let me share my screen first. Bear with me a second. Just let me know if you can see this.
Yes, sir, we can see.
Wonderful. Thanks for the introduction, Soumya. I appreciate that. And thanks for giving me the opportunity to share my experience with you all. I have about 30 minutes or so to summarize everything we've been doing in past 16 months. Therefore, I'm not going to spend any minute talk about myself. Let's keep that for another day, shall we? What I would like to do today is to give a sense of how a government organization can utilize mathematical or statistical models to inform their policy decisions that has had a huge impact on controlling this pandemic. However, I only can tell you my end of the story, and I would love to hear yours as well. So let's save some time for that discussion. As free to ask any question you have at any time, or just keep them for the Q&A session. All right, before I begin, I need to say that during this presentation, I'm not presenting or talking about any sensitive patient level information following the Nova Scotia Privacy Act. This material was prepared based on publicly available data and information. All right, first of all, let me set the background for our discussion by introducing some important keywords that will give you an idea of how infectious diseases do what they do. When and why should we isolate people, and how long should we isolate them for? This depends on 3 key features of infectious diseases: the incubation period, the latent period, and the infectious period. Starting with the incubation period, this is the time from when infection is first acquired to when someone first shows clinical symptoms. The latent period is a time from when the infection is acquired to the time when someone can first infect somebody else. And this is followed by the infectious period, the time during which an infected person can transmit the disease to others. So how do the incubation period, latent period, and infectious period fit together? Well, it can be in different ways depending on the disease. For SARS-CoV-2, also known as the coronavirus, the incubation period is longer than the latent period. What that means is people get symptoms only after they have become infectious. So people could start transmitting the disease before they have any symptoms of the disease, when they still appear to be totally well. That helps an infection to spread because people are out and about, right? They don't know that they are ill. There are some other disease types shown at the bottom here. The incubation period is shorter than the latent period. That means people have symptoms before they are infectious, before they can transmit to other people. So living in a pandemic for 16 months, I'm pretty sure you have all seen and heard about these keywords. While the next parameter I'm going to introduce is an important one. It is the basic reproduction number, also called the R0. We use this value to describe the contagiousness or the transmissibility of infectious patients. It is the expected number of secondary cases. Means if you live your normal life with no restrictions, without following any public health measures, and if you get infected, how many will acquire the infection directly from you? This can take a value above 0. If it is below 1, then the disease will not further spread. If it is above 1, then the cases will rise exponentially. It cannot be 0. If it is 0, then the disease is not infectious anymore. Here you can see R0, basic reproduction number, for a few infectious diseases. Well, the basic reproduction number is often misinterpreted or misapplied, because once a pandemic starts, you will not have normal conditions around you. Governments will quickly act and put necessary restrictions to control the spread, right? Then the R0, the basic reproduction number, is not a valid number anymore. Instead, we will have a new reproduction number, which is called a effective reproduction number. That is obviously lower than the basic reproduction number because of the restrictions. The reproduction number, and this is one of the simplest formulations. The reproduction number can be calculated from these 3 variables. Infection probability is the chance that you catch the virus from another infected person if you have a close contact with him. Contact rate is the average number of close contacts you have in a given day. And infectious period is the duration of infectiousness, as we speak earlier. So, governments implement public health measures to control the pandemic, right? So what they really do is change these variables to try to bring the reproductive number below 1, so you can control the pandemic, control the growth of the cases. For example, wearing masks and other hygiene practices will lower the infection probability, right? And social distancing and other physical restrictions will lower the contact rate. And there is only one way to change the infectious period, because it's a disease-specific parameter, that is just only by vaccination. So we can see that all these mitigation measures involve individuals. If individuals do not wear masks, average, if individuals not get self-isolated, then your contact rate will not go down. Hence, the reproductive number will not go below 1. Public compliance is key in controlling a pandemic. I cannot stress that enough. Public compliance is key. And earlier I said that if R is above 1, the cases will rise exponentially, right? If you remember, and this is why it is true. Every generation, it multiplies by power of R. So that's so those are the key parameters that we use in modeling infectious diseases. All right, now we are ready. Let me start with explaining the role of my pandemic modeling team. I work for the Ministry of Health of this province, which is solely responsible for the pandemic response plan. The primary job of this team is to provide analytical insight to the minister and the other decision makers so we can take informed decisions. Because of our work, the government always knew what they are walking into and what to expect. Remember, this is very different from academic modeling projects. In academia, you have time to do your research, right? But here we have to make decisions in real time. We were always run against time. Our goal was to make those decisions as accurate as possible. We used a range of epidemiological models to generate actionable intelligence. Let me stress that again. We produced actionable intelligence. That means a data-driven insights that the government can act on. I will talk about one of those methods today and how those models help decision makers. Excellent. So let's see what happened here in Nova Scotia. This is the daily reported case count trajectory in Nova Scotia, adjusted to a 1 million population. We had a significant wave at the start. Then we managed to control it, and then we had a long period with no waves. And the second wave is tiny, very small. Then we were hit by a massive tsunami of cases in the last April and May period due to the Alpha variant, also known as the UK variant, the B.1.1.7 variant. But the fact is, we managed to control the wave pretty quickly. In technical terms, we managed to bring our effective reproductive number below 1 quickly. So how this is look like compared to what happened in Sri Lanka? There you go. So you never had a first wave, actually. The spread started in the end of 2020. That triggered a long wave. What does that mean? That means public was not adapting to restrictions quick enough. That changes effective reproductive number very slowly. In fact, small long waves are much more dangerous than large short waves because they add infectious individuals to the community for a long period of time, and that will make it difficult to stop the spread. However, then in early 2021, here, you somehow managed to control it. Then boom, the New Year season started, right? And then the Alpha variant came to all the New Year festivals. That formed another huge long wave, which is still ongoing due to other more infectious variants like Delta and Lambda. At the end of this pandemic, we will run out of Greek letters to naming them. Well, this is the history and the present. But we are not interested in that. We are interested in foresee the future scenarios. Let's see. Let's focus on what are the different stages of pandemic modeling. In different stages, we have different questions to answer. Suppose this figure represents 2 consecutive waves of cases, hypothetically. So what questions do you think decision makers have in the beginning of the wave? So we want to know what to expect in next 7 days, right? And when to implement public health measures, when to implement lockdowns, when to close schools, right? And when we will reach the peak of this current wave, which is very important because that will have a huge impact on your acute care system, the hospital system. And what is the expected size of the peak? How many daily cases we are expecting at the peak of this wave? And what is the expected impact on the acute care system, as I mentioned earlier? And eventually, thanks to the restrictions, we will reach the peak and cases will start going down. Sorry, my phone is ringing. Now the government needs to know when is the right time to lift the restrictions without triggering another wave, and when to lift what restrictions. For example, when to reopen schools, when people can go back to work, so on, right? Then if you are lucky, there will be a silence period between waves. But we cannot stop our work. We need to see how can trigger, when and how can trigger another wave. Importation modeling is key to answer that question. That models how an infected person can come from another jurisdiction, not from another place, from another country, and form a wave where you live. This might be very useful for island nations like Sri Lanka, because if you don't have the virus in already, then there is only one way to get it in, right? So from another country. So for all these questions, except the first one here, the short-term forecast and the importation modeling, for all other questions, we can answer by system dynamic models. So what is a dynamic system? Dynamic system is a collection of interconnected units or entities that has a constant flow between them. In simple words, it's a giant network of multiple units with inflows and outflows. Dynamic systems are often focused in physics, but let me give you a general non-physics example, a traffic light system. This is a dynamic system with constant flow. If the inflow traffic from the north exceed the outflow to other directions, that will create a traffic jam or a bottleneck here at this color line. So this is a dynamic system. This is a system of roads, vehicles, pedestrians that all are interconnected. Another example, your entire health system is a dynamic network. The health system consists with different components, right? So hospitals, emergency departments, family doctors, and other institutes, and also you who live in the community. And there are inflows and outflows between these components. When there is a pandemic, the inflow to the hospital component will rise, and we need to adjust other components to accommodate that increase. We might have to cancel appointments, postpone surgeries, increase capacity and workforce, so on, right? So everything is connected in a dynamic system. Another example is your university that consists with different faculties and departments. Every year, some will go out and a new set of students come in. That's a dynamic system. If the government needs to increase the next year intake, then we need to increase the capacity inside university to accommodate that. Everything is interconnected. A decision you make about one component has impact on others. That's the characteristic of a dynamic system. So let's see how we can see infectious disease transmission as a dynamic system. We divide our population into different subgroups according to their disease stages. Starting with susceptible group, these are the people who don't have the disease yet, but potentially get it in the future. Some of these susceptible individuals may become exposed to the virus by making a close contact with an infected patient, and that is the second subgroup, the exposed subgroup. Then these exposed individuals will become infectious. That is, they will start transmitting the disease to others. Then eventually, these infected individuals will recover or die by the infection and removed from the system. Each member of the entire population belongs to one of these subgroups. This is a dynamic system. There is a flow between these subgroups or compartments, we call them. This is called the SEIR model in disease epidemiology, which is the most basic epi model. To model this system, we need to estimate the rate of changes, rate of inflows and outflows. To do that, we use a system of differential equations. I'm not going into too much technical details. However, I want to say this model, as it is, cannot produce any accurate predictions due to its simplicity. So we need to reformulate this according to the question we need an answer for. Let me give you an example. Well, before I give you an example, let's see what are the often used pandemic control strategies and how we reformulate our basic model to answer those questions. The first one is the quarantine and case isolation method. We detect infection individuals, place them in isolation centers, and trace their close contacts and quarantine them. This was Sri Lanka's main focus during the early stages of the pandemic. This sounds very simple enough to implement, but it is very challenging in practice. Especially, it becomes very difficult when the case count exceeds a certain limit, because number of close contacts to trace back and quarantine will rise exponentially. And at one point, the government or the public health system will not have enough workforce to do the job. The second method is implementing public health measures such as masking, closures, travel restrictions, etc. Given a good public compliance, this is more effective than the first one. However, most countries use combination of both methods. So let's see an example how we can reformulate the basic SEIR model to answer some questions. Now, suppose the government needs to know how many close contacts should be quarantined and how many cases should be isolated to have a manageable way to control the pandemic. In other words, what are the optimal quarantine and isolation rates? To answer this question, we reformulate our previous SEIR model by adding some extra components, compartments. There are two exposed compartments now. In this compartment, we have all the individuals who are exposed to the virus, but do not know that they were exposed. And this is a new compartment. We have everybody who were close contacts of a non-infected case. In other words, those are the close contacts that were successfully traced and quarantined. The rate that susceptible person become an exposed quarantine person is the quarantine rate, right? We also have two infectious compartments here. The quarantined individuals will move to this compartment, infected, isolated compartment eventually. They are already detected, right? So no problem there. But some of these unknown exposed cases, individuals will be detected and isolated later. To do that, what we have to do, we have to increase our testing capacity. We have to do more and more random tests to identify these guys and isolate them, right? But we will miss some of them and they will not get isolated and keep spreading the virus. The rate at which people are coming from this compartment to this compartment is the case isolation rate, depending on your testing capacity. Now, with this formulation, we can solve this system to estimate quarantine and isolation rates. For example, the model can tell you that what needs to be done to control the wave. For example, it can tell you to control the transmission, 60% of exposed close contacts need to be traced and quarantined, and 80% of asymptomatic cases need to be identified and isolated, right? So based on this intelligence, public health or the government can make decisions. They can take decisions to increase call center staff to trace close contacts and let them know that they were exposed, right? They can take decisions to enhance the testing capacity. Enhancing testing capacity has other implications. For example, you have to recruit staff and train them, right? You have to purchase additional testing kits, right? So you have to find money for that. So there are lots of decisions that the government can make based on this intelligence, right? Now let's see how we model the effect of public health restrictions. The most straightforward way to do this is very effective R calculation over time. To do this, we usually use results of other studies in virology and historical data to do this accurately. For example, some virology studies have shown that the transmission probability of coronavirus can be reduced by 20% by wearing masks only, right? So that's a quantifiable intelligence. However, changing contact patterns and other human behaviors are not that straightforward. We often use Google and Apple mobility data as a proxy for individual movements. And at some point, I remember we had agreements with mobile companies to give us data on movements between geographical locations. However, we know that with perfect public compliance, it will at least take one infectious period to see the effect of restrictions in case counts. What does that mean? That means if you implement a lockdown today, you will not see cases are going down until 2 weeks from now. That can be even longer if the public compliance is poor. This figure to your right-hand side shows the effective R changed over time after a lockdown. So we implemented a lockdown here, and it took exactly 14 days, a one infectious period, for it to go below 1. But if we had poor public compliance, that will take even longer, more than 14 days to get below 1. And that will form a long wave again, right? So again, public compliance is key. Let me skip this slide to save some time. And this is a schematic of a complete compartmental model. It includes disease stages as well as hospitalizations, ICU admissions, ventilator usage, and other resource usage, and so on. The underlying system of differential equations is very complex and computationally challenging to optimize. So you can see it start with the susceptible people. There are exposed, unknown, infectious, asymptomatic infections, severe cases, mild cases, and some severe cases go to hospital, some goes to ICU, and pre-ICU, then ICU, then back to hospital. You know, it's a complicated, a dynamic system. So this is this is an example of a complete compartmental model. Okay, one more slide and I will show you some results. We know that different age groups have different contact patterns. The figure to your left shows the age-dependent contact patterns. The bright diagonal here tells you that people tend to connect more with people in the same age group as they are. The two subdiagonals shows how individuals mix with their parents, teachers, and grandparents, and vice versa. So what I want to tell you is, what I want to show you, it is not accurate to assume a single contact rate for a whole population. Moreover, the virus acts differently on different age groups. For example, older people tend to develop symptoms more often than younger people. That tells you that we need to do more asymptomatic testing focusing younger groups, right? Also, older people have higher chance of being hospitalized, right? So it is clear that we need to take age structured information into account when we estimate these models. That means, in technical terms, we need to use matrix algebra to solve our already complex system of differential equations. That's fun. Anyways, let's see some results we obtain using some of these models. The third wave in Nova Scotia started with the alpha variant, and cases ramped up pretty quickly, and we went for a lockdown immediately. So we needed to know, after the lockdown, how long this will take to reach the peak, and what is the size of the peak, and how long this wave will last, right? With all the available information and trusting our people's compliance, we modeled it, and you can see how accurate the model was. The model estimated the peak date, the peak size, and the downward trend almost perfectly. We modeled at this point of time, soon after the lockdown. So the blue line is the forecasted trajectory, and the dots are the actual reported cases. Then we used the same model to estimate the ICU admissions. We are worried about our ICU system because it has very limited capacity, and the actual ICU admissions followed the forecasted trajectory pretty well. Right, another example, when cases starting to ramp up, we knew that having another wave is inevitable. Then the question is, when is the right time to implement a lockdown to save our ICU system? To answer this, we reverse engineered our SAIR model and estimated when should be the lockdown date. We call that an action point. If we implement a lockdown when we have 20 daily cases, then our ICU system, limited capacity ICU system, will be able to serve for those who need without any problem. The public health followed our recommendation and implemented a lockdown once we see 20 daily cases. Right, the last example. We started our vaccine rollout in early 2021. At one point, we wanted to know, what if we have another wave during our vaccine rollout? Why that is an important question? Because we had limited workforce. Everybody was focusing on vaccine administration. And if we have another surge of cases, then we need to be able to find additional workforce to deal with those patients, right? So we simulated a hypothetical scenario, introducing a community exposure event during the vaccine rollout. At that point, 23% of the population have received their first dose. The analysis showed that under the original COVID variant, we will not have another significant wave. However, Then the alpha variant came into the play, which is 50% more infectious and not controllable with one dose. We took that info into account and reran the model, and we see that we can expect a significant size wave. So that's exactly what happened, and the government knew what we were walking into, and we were ready to take actions when necessary, right? I think we are running out of time, but let me quickly introduce you another flexible version of system dynamic models, also known as agent-based models. In the previous discussed compartmental model, divide your whole population into subgroups, assuming every individual behaves the same way. That's what we call the assumption of homogeneity. That model also assumes perfect mixing. That means anyone can get connected with anybody. These assumptions are not really true in practice. On the other hand, the agent-based modeling, we model individuals, and that allows us to take individual level attributes into account. Agent-based models assume each individual behaves based on his own compartmental model. Very complicated, eh? He or she has his own transmission rates, own behavior patterns, and also he has his own different other attributes such as age, gender, income, social status, and so on. And your population consists with thousands of these different individuals. Now, this is computational demanding model. Compartmental model governs by a single system of equation, if you remember. An agent-based model needs a collection of those systems to be estimated. Right, without going into details, to save some time, let me show you some examples. Agent-based models are frequently used to do scenario analysis. For example, let's simulate a super spreader event. Apparently that's pretty common in Sri Lanka. I have heard lots of stories about infected individuals going around in their villages, communities, attending to parties and events, so on. So let's simulate a super spreader event. My apologies, first of all, if this figure is unclear. These green little things supposed to be people, if you see that clearly. But let me explain. This is a population of 1,000 people. No restrictions implemented. Citizens can connect with anyone within 100 kilometers distance. However, the average contact rate is 10 contacts per day. The lines connecting individuals show their contact network. Now, this guy here is our guy. He's infected. He's the one who goes around his community and spreading the virus. Let's say he met 50 people in this community, and let's see how fast he can spread the virus through his village. The disease stages are color coded, so you can see the color of these individuals changing based on their disease stage. Earlier it is very slow, now it's getting fast, eh? So these curves here shows the trajectory of each stage. Well, that was fast, eh? Well, as I said, these curves indicates the daily trajectory of different disease stages. How many are infected, how many are exposed, how many are in hospitals, and how many are in ICUs. The black line is deaths, right? So on. Okay. Now let's see what happens if our super spreader lived in a community under restrictions. In this community, members have small social bubbles because they are under restrictions, but our guy, he still meets 50 people, but this time he's not successful as he was before. This shows, so you can see there are small localized outbreak here, a localized outbreak here and here, but it is not spreading through your population. And this once again shows the importance of public health measures and social distancing. Another example, I'll be quick. We can use agent-based models to simulate specific social units like schools, villages, offices, etc. Suppose there is this village of 50 families at risk. We want to know how the virus will attack this village. Each family has 2 to 5 members. Each member goes to work or school, depending on their age, and come back to home. End of the day, patients can infect others at home, at work, at school, etc. And patients stay home if they have symptoms and go to school or work otherwise. So this is the visual representation of the village. 50 families, 5 workplaces or schools. Different families have different number of members. At the start, there are 3 exposed families, 3 exposed individuals in 3 families. Now let's see how the virus spread under no restriction. So people are going to work or school and come back home with or without disease. And this curve here shows the active case count in each day. Right? So under no restriction, the attack rate is really high. At the end of this simulation, you will see there is only 3 families left without being infected. Then we can implement some detailed restrictions. For example, we can close schools. Then school-age children will stay at home. Or we can implement a working from home policy and see that's impact. Likewise, we can test hypothetical scenarios and figure out the best public health measure to save this village before it's too late, right? Okay, let me give you one more example and I will wrap this up. Recently, we wanted to know what to expect with the new Delta variant. The Alpha variant is 50% more infectious than the original variants, but the Delta variant is 40% more infectious than the Alpha variant. That makes it twice as infectious than the original variant, right? And the first dose of Pfizer and Moderna vaccine can give only 30% of immunity against Delta. So to see the effect, we simulated a scenario where 70% of the population has received their first dose, and we will start delivering our second dose once we reach 80% mark with the first dose. We simulated 2 scenarios, a 4th wave with Delta variant during the vaccine rollout under restrictions, and the second scenario is with no restrictions. All right, every dot is a member of this population of size 1,000. Light blue dots have already received their first dose, right? Green dots, they are unvaccinated. Once they become fully immune, fully vaccinated, they will become blue in color. Let's see how it goes. This simulation shows that even though we have 70% population done with the first dose, we still can have a significant wave if we do not have restrictions. Delta variant is that much infectious. I think you don't need any examples. Sri Lanka is going through that right now as we speak. So the last scenario, if we implement some restrictions, then we will have small social bubbles. Now we will have a manageable wave. This once again proves the importance of public health measures and public compliance. All right, I took 40 minutes, I'm sorry. That's all I have today. Let's see what are the key takeaways of this session. All the statisticians, data scientists, and out there, undergrads, this must give you a comfort about the field that you have chosen, right? The data scientists have done a tremendous work to control the pandemic. They have been a key component of the process to develop pandemic response plans. We were not in the back, we were in the front of this battle, guiding the policymakers with our data-driven insights. So you're on the right track, keep going. And all the decision makers and leaders, what can I say? Be brave to use statistical insights for decision making. Data is new gold. Use it. Be strategic. Zoom out a bit and see the big picture see how things are connected, see how individual events drive the pandemics out. Your decisions can save lives. Make them wisely, make them accurate using data. So I will wrap this up and let's open the floor to the discussion. Thank you.
Thank you, sir, for that informative and insightful speech. Hello, everyone. I'm Sarah, and I will be conducting the Q&A session for the evening. We had a couple of questions coming in from the audience with regards to your speech, as well as a few general questions. So let me move into the first question. Sir, how flexible is the government in taking advices from health data experts, and do governments implement them immediately?
Well, I'm a public servant, so we are really lucky in this province because we got a chance to work with the public health and the other decision makers pretty closely. So they always listen to us, they always look up to us. So whenever we have a surge of cases, they look up to us and ask us, hey, what's going on, what to expect. But there are other jurisdictions, even within Canada, in other provinces, governments are not listening to the data experts, the data scientists. That depends on the pandemic situation, right? If there is a huge wave and the governments are panicked, you have to make real-time decisions, right? I remember for last 16 months we were running against time. We didn't have deadlines, right? Our deadlines were yesterday, so it's already passed. We knew that our decisions save lives, so we were in stress. So I cannot blame the government that not listening to us, but some governments do, some governments don't. I have both experience, so that really depends on the situation. And the other thing is, if your statistical insights are not actionable, then government will not listen to it.
Okay, sir. Thank you. There is another question coming in from the audience. Do you think Sri Lanka will reach herd immunity at this rate?
Well, herd immunity is a myth, right? I mean, it's highly theoretical. The herd immunity doesn't mean that you will eradicate the disease. The herd immunity means the vaccine will take the control, but you will still see cases. It's like general flu, right? So I don't know whether you are giving flu vaccines in Sri Lanka. Maybe not, but we are giving flu vaccine in Canada every September. But we always see flu pandemics, right? So the herd immunity doesn't mean that you won't see COVID cases anymore. Herd immunity means that your COVID cases are manageable. That's what it means. So I really don't have an answer for that because we don't have enough information. Because if you see Singapore, 3/4 of new cases or 2/3 of new cases are already vaccinated people. So we really don't know these vaccines are working or not, right? So I mean, to reach the herd immunity, vaccine should be working, right? Otherwise it wouldn't work. So we really don't have enough data, enough accurate data to say that any country will reach herd immunity soon enough. So what we have to do is we just wear your mask and keep your distance. That's all we can do at this moment, and take your vaccine when you get your chance. That will give you some immunity. Something is better than nothing, eh?
Okay, thank you, sir. And then there is another question. What are the limitations of system dynamic models that you've spoken today?
Good question. The first thing is they are computationally intensive. For example, I showed you agent-based models of population of 1,000 people, right? So that was pretty quick to simulate. But our populations are, for example, the population in Nova Scotia is little about 1 million. To simulate 1 million people, it will take weeks. So Sri Lanka has 22 million. So just forget about it, right? So that's one limitation. The other limitation is quantifying the behavioral effects. It's very hard to quantify people behavior. There are some other techniques like choice models and other metamorphic models, but it is really hard to quantify it accurately and take that quantified information into the system dynamic models. That's another limitation. Another limitation is before you formulate your system dynamic model, you have to identify the dynamics of your system. If you miss the dynamic of your system, for example, the health system diagram I showed you in one of my slides, there are arrows going from community to hospital, hospital to emergency departments, and it's all are connected. If you miss one of these arrows, then your system is not complete and your estimations are not accurate, and you will end up doing wrong decisions. So first you have to identify the dynamics of your system accurately. That's very hard. That's very tedious. You have to zoom out. You have to see the big picture. You have to see how things are connected first. That's a one challenge. Well, I can name a lot, but these are very powerful models as well if you have the right information and right data.
Thank you, sir. So there is another question about the model. Apart from modeling a pandemic, in what other areas are system dynamic models utilized?
To model any system, any dynamic system, for example, emergency departments. That's the first example came into my mind because we did a emergency department model a few months ago. Emergency department is a super dynamic system, right? So there are inflows. People can walk in. People can come from ambulances. People can drive in. Then there's a triage process. Doctors categorize these people based on their acuity, their severeness, and then they will guide through different departments of the within the emergency department. Then some people will admit to the hospital, some people will discharge to home. That's a super dynamic model, super dynamic system. So we can use system dynamic models to model any dynamic system, and we have used a compartmental model to model a university, faculty of medicine in Nova Scotia University. The government wanted to know how many additional psychiatry seats we need to fill the gap of psychiatry specialists. So we have used system dynamics model for many other purposes other than modeling a pandemic.
So it definitely extends out of the box.
Oh, yeah.
So the next question is, how do you think statistics will be used further for the recovery process of this epidemic?
Good question. I'm an economist as well, so I always see the economical impact of everything, right? So we can use statistical insight to recover our economy, right? So for example, let's take the health system as an example. So every country, every government has health expenditure. So if you have a full health expenditure model, then we can see, well, health expenditure model is a system dynamic model as well. It shows how money flows your health system, how much you invest into your hospitals, how much you invest to improve your mental health services, how much you invest to family doctors, right? Those kind of things, how much you invest on vaccines, not only COVID vaccines, but all other vaccines. So primary health care, population health, everything. So that's a health expenditure model. So if we have a sophisticated health expenditure model, we can see how COVID has impacted to the money that flows through the system, right? So for example, let's say after everything, after this pandemic, Sri Lanka received $1 billion donation to improve its health system, right? So where to invest? There are lots of places to invest, right? So I mean, then you can use system dynamic models as well as other statistical models to see where is the right place to invest. If you invest that $1 billion to improve your health system, what is the opportunity cost? What options did you miss? Could you use that 1 billion to improve your mental health? Because COVID has a huge impact on mental health of the people, right? So those are the big questions. So those are the why questions, why we do this. And then you guys, the statisticians and data scientists, will figure out what and how, what to do and how to do that, right? So there are lots of applications of statistical modeling and system dynamic models even after COVID.
All right. So since we're running out of time, let me move on to just a few questions. These are general questions that we have received. So the first one is a little comprehensive and long. Sir, you are one of the directors for data science, digital health, analytics, and privacy in Canada. So you are in fact fluent in the field of digital health. Now in Sri Lanka, digital health is not that popular. So if I'm not mistaken, under its umbrella, digital health includes mobile health apps, electronic health records, electronic medical records, and so on. So what advice would you give us Sri Lankans, especially in these times of the pandemic, as to how we could best utilize these digital health resources, and how far is it reliable and accurate?
Good question. We just started our digital health project here in Nova Scotia. Well, let me give you an example. There is a scale that runs from 1 to 7, I think, that quantifies how digitized your system is. So the 1 is fully paper-based and 7 is fully digitized, right? So when we start our digital health project here in Nova Scotia 3 years, you muted me. Anyways, when we started our digital health project 3 years ago, we were ranked even below 2, that we were fully paper-based, pretty similar to Sri Lanka, but we have came a long way, and now our system is fully digitized. So before you utilize the advantages of a digital system, you have to start digitizing your system. That's the start. I mean, just go to a government office in Sri Lanka. How many paper files you can see, and how many computers you can see, right? Your system is not digitized enough to take the maximum out of it. And people can, I can think of lots of examples, but people can fraud many things if your system is not digitized, right? I mean, you can misplace a file pretty easily, and you're not in the system anymore then, right? And think about if you're moving from Anuradhapura to Hambantota, that you are relocated due to your work, and you have to take your medical files with you and hand over your medical files to your new doctor. If you have a digital system, you don't have to do that, right? So all are interconnected. So those are the positive things of a digital system, right? So it's kind of one patient, one record thing, right? So each patient has a one record, each person has a file, and And the drawback is the privacy. There are lots of privacy implications of digitizing a system because your entire life is in a one place. So if I have an access to your unique ID, then you are done, right? So you're exposed. So that's the main drawback. But if you have implemented a proper privacy system, privacy data system, and a security system, that won't be a problem. That's what happened here. So I can talk hours about digital systems. That's a discussion for another stat day.
Yes. Thank you, sir. And sorry about the technical difficulty about muting. That was a
Oh, no worries, no worries.
All right. So there are a lot of questions coming in, but we're running short of time. So we have to end today's Q&A session. It was indeed an interesting and knowledgeable session. Thank you very much, sir. Now I'd like to invite 𝘵𝘺𝗵𝘃 to deliver the vote of thanks.
Before that, Sarah,
Yeah.
give me a sec. So thanks the organizing committee for inviting me. And I would like to keep this discussion alive. If you have any question, if you have any stories to share with me, if you have anything to ask me, just drop me an email. You can get my contacts from 𝘵𝘺𝗵𝘃 or someone from the organizing team. And let's keep this alive. Thanks much.
Thank you, sir. Thank you very much. 𝘵𝑚𝑖, over to you.
Thank you, Sarah. Thank you very much, sir, for gracing this occasion and for sharing your insightful knowledge with us. Thank you for enlightening us with that very informative speech and for answering all the questions that we had. It was a great privilege and pleasure to have you with us this evening. Thank you very much. I would also like to take some time to thank our sponsors, London Stock Exchange Group, our platinum partner, Equity Knowledge Partners, our gold partner, Potenza, our silver partner, Creative Hub and Slam Power Solutions, our mutual partners. We are very grateful for your generosity in helping to make this event a success. Thank you very much. So ladies and gentlemen, it's time to mark the end of the second session of Stat Day 2021, the guest speech. The third session of Stat Day 2021, the research presentations conducted by the recent graduates of the Department of Statistics, University of Colombo, will be held on 13th of August from 5 p.m. onwards. See you all on that day as well. Before we finish, I would like to invite you all to pose for a virtual photo. For that, please turn on your camera for a minute if possible. Thank you so much for joining us.